Hi, it's 12:01 and you are here with MiHIN. Thank you so much for being here for our convening. We call it the download. Big topics, the why and the who of health information exchange in Michigan. Today this is really a special one. We're talking about how you can use health information exchange to connect with each other. Next slide, please. I want to really quickly thank our funders for today's convening. Michigan Veteran Service Organization Networking Grant offered by the Michigan Veterans Affairs Agency. We are so thankful and we're so proud to be here. Here's our agenda. We'll do some welcomes. We will tell you who's come to talk to you today and why. And they will move through this program to leave you in a place where you are asking yourselves and asking your teams important questions about the questions you all ask your patients and the people you provide care for. MiHIN. MiHIN is Michigan's state network of state health information exchange. We are designated as the nonprofit organization responsible for the secure, legal, and private exchange of personal health information between various sectors of care. Next slide, please. The premise of a health information exchange is pretty simple, but it's not easy. The idea is that there are many people caring for any one human being at any one time. And for all of those care providers to connect with one another, they would have to connect over and over and over and over again. They would have to connect disparate systems and agree on how these disparate systems were going to communicate with each other. And instead, they connect once to their statewide nonprofit designated entity to send and contribute information and receive information about shared patients. So MiHIN connects with MDHHS. We connect with about 97% of the hospitals and health systems in Michigan. We connect with pharmacies and primary cares and clinics and community mental health. We exchange lab and radiology and clinical documents, all so that everybody can really see the full picture of who they're taking care of. Again, just a quick illustration. You could connect 3 million times, or you could connect once. We think you should connect once. I am so thrilled to actually invite our speakers to introduce themselves today and give us some context about why they're here. Really, Dr. Bonesack and Andrea, we've been really looking forward to this. So please take your time and let us get to know you.
Thank you, Joanne. So I was tagged to introduce myself first. So my name is Dr. Kevin Bonesack. I grew up all over Michigan and did my medical training then in Chicago. And as I was heading off to do that medical training from a funding and serving your country standpoint, I joined the Air Force. It was 1994. At the time, it was the Cold War dividend. Don't have to go off to war anymore. Well, that surprise happened 7 years later with 9/11, exactly when I was finishing my family medicine training and went active duty for the next 10 years. I was in 4 different duty stations, including North Carolina, Germany, Nebraska, and Texas, but also had 4 different deployments that I'll be talking about a little bit later. I joined the Air National Guard 14 years ago and served another 11 years for the state of Michigan, and finished up after being in Battle Creek at Lansing at headquarters as the state air surgeon. honored to continue to serve civilian populations within my role as the Population Health Management Executive Director within Trinity Health. And with that, I get to hand over to Andrea to introduce herself.
Thank you so much, Dr. Bonsiak. So my name is Andrea Norton. I am a social worker by trade, and I am a Michigander as well as born and raised. And I made the short-sighted active teenage rebellion decision when I was 18, a month out of high school, to join the Air Force, where I spent 8.5 years as an intelligence analyst and a mobile instructor. So I traveled quite a bit to teach an analysis course. When I got out of the military in 2007, I went back to school at Michigan State. I'm going to talk a little bit about my time there, that military transition time. It's very, very challenging for most military members, but I've been serving as a social worker with working with veterans my whole social work career. I started out at Volunteers of America and their transitional housing program in Lansing, and then transitioned to the Saginaw VA, where I worked for 10 years in a variety of roles in their homeless program. I managed their women veterans program, and then I worked about 3 years in community engagement in the suicide prevention program. And I just recently transitioned to the state veteran agency in January, but I've been collaborating with folks at MVAA for quite a few years. So it's really nice to be familiar with the team there and the organization. So I'm excited to share a little bit about that a little bit later in this presentation, but really happy to be here and hope to help you serve our veterans in a much more streamlined capacity. So I start out just about every presentation, no matter who it is to, with this question. I think it's a really helpful question to kind of to help ground us in really talking about the population. When I ask this question, what does a veteran look like? Most people will have an image in their head right now, and it typically is a Vietnam era veteran, white, middle-aged man, usually with the hat and patches, some signifier that that person is a veteran. And what I want to do, because I used to ask this question in new employee orientation when I worked at the VA. So people at the VA still had the same kind of image in their head. And it was across the board, it's almost 100% of the time, it was the same kind of image. And I just want to, if you want to go to the next slide, really expand your idea of what a veteran looks like, because every single person in these pictures is a veteran. So they're all races, all ages, all genders. It is the most diverse population that you can imagine. It's really a microcosm of society. So as diverse as society is, the veteran population will mirror that. So when I say veteran and when you hear about veterans, really understand that it is a very diverse population. And even within that population, there's a lot of different needs that exist within the veteran population. So, you know, it is not a one size fits all, but there are some universal things that are unique to the veteran experience that civilians don't necessarily experience. But another question that I do like to ask is whether veteran is a title or an identity. You know, if you think of it as merely a title, what you're called when you're no longer serving in an active capacity, it's one thing, you know, because it can be both. It can be a title and an identity, but if you don't recognize it as an identity, what could be the implications of that? You know, when you think of in healthcare, for instance, identity matters. It can mean, you know, the different health disparities that exist. It can mean the different different ailments or diseases or whatever that affect certain populations more than others. It can be the access to services and what you offer based on the population's needs. It can mean a whole lot of things. You hear about having an intersectional approach. Well, if veteran is recognized as an identity, is that identity also included when you're looking at other identities in an intersectional way? Because it does affect someone's it affects their healthcare tremendously. It can be either certain unique conditions that affect this population more so than their civilian counterparts, but it can also be how what their relationship is to healthcare, how likely they are to utilize it, how likely they are to to follow through, or to who they seek out in healthcare as well. So, keep in mind that it is also for the population recognizing that a lot of veterans will hold on to that identity, and that is a very meaningful thing to them. And then there are some that will never admit that they are a veteran for a variety of reasons. Sometimes within the own community itself, there is this, well, you're not a real veteran, you didn't serve in combat, or you're not a real veteran because you're a woman, or you're not there is that even within the community. But then, how identity is a very personal journey. How you come to call yourself whatever, that's a personal journey, but we can still find ways to help those, even regardless of whether they self-identify, if we're asking the right questions, which we'll get into a little bit later on. But I really want to, make sure that you understand that the veteran population is incredibly diverse. So it is not a one size fits all. Next. So, as I said before, there are very unique healthcare concerns that veterans experience that their civilian counterparts might not. It's a very unique environment that they serve in. So a lot of musculoskeletal injuries from maybe equipment that, they had to wear that civilians typically don't. Or for women veterans, maybe the equipment was not designed for their specific bodies. So it can cause health concerns down the road. Chronic pain is a large one. Mental illnesses, different PTSD, TBI. Toxic exposures is a big one. Maybe you've heard in the last few years the passage of the PACT Act. That really opened up a lot of eligibility and access for a variety of veterans who might not have been eligible for VA services before that. So really opened up a lot of doors for veterans getting access to care. But, the toxic exposures from whether serving, in a deployed location where things like burn pits occurred, or even on some of the, Navy ships being exposed to different fuels or different toxic elements in their line of work, that can cause health concerns down the roads. And then also military sexual trauma. There is, that affects someone's ability to get care as well, because for veteran resources, sometimes people look at them as an extension of their military service. Even though the VA is different from DoD, it still is seen by some as an extension of that. So based on your time in the service and what you experience can be your reluctance or your embracing of those veteran resources. So that can be a barrier to some if they didn't have a good experience. And again, I always make note that all of those different health conditions, different veterans will experience them differently. So, the rate of different races, different ages, different what you came into the military with. If you already had certain conditions, they could be exacerbated. So it's not like I said, a one size fits all. Some within the population, there are different rates of those ailments as well. Now, what I do in my role at the Michigan Veteran Affairs Agency is really, you know, when I asked those questions in the beginning, it was to get you to really address your own bias, because this is a bias that our culture has created, because what you see on the news, what you see in movies and TV is really a lot of times one veteran story. And so my job is really to help, you know, underserved populations access care, to develop outreach solutions to getting into those communities so that they understand that there are veteran resources, and to educate. It's really about educating the community about veteran resources, educating the veteran community about community resources, and making sure that there's a safety net so that nobody falls through the cracks. So it's a lot of advocacy, it's a lot of outreach, it's a lot of education, but it's really expanding people's idea of what we mean when we hear veteran too. So that's a little, it's really, I'm kind of a bridge position, if you will. Next slide. And really about, I listed, I was thinking back to my own transition experience, and, you know, you hear about social determinants of health a lot in healthcare, but like, this is an example of one veteran's transition experience and all of those other factors that really played a huge part in having about 2.5 years, 3 years almost, that before I actually sought veteran services. Because when you're in the military, you know, they really, in the Air Force especially, I think this is one of the values that stuck with me even present day. If you take care of your people, they will take care of the mission. So the Air Force, I think, remarkably well really embodies that, because that's why we have the best chow halls, the best housing, the best base resources. I mean, all the other services will tease us about being silver spoon fed or whatever the case may be, but the Air Force invests in that quality of life. They really want airmen to be, you know, really concerned with the mission and not taking care of their family. They want to provide those resources so that stress doesn't exist. And it was great. I'll be the first to admit, you know, when I got sick, I went to the clinic. The doctor who was trained decided, you know, through collaboration, we talked about what would be the best treatment. Sometimes it might've been medication. I went to the pharmacy, I picked up my medication, and I went home and to get better. At no point was there an insurance company telling the provider or myself what I could or could not do. There was nothing interfering with that patient provider relationship. So then you get out of the military, and now all of those services and resources are taken away. But also a big thing that's taken away is your sense of identity. If the Air Force told me in 1998 who I was after I graduated boot camp and whatnot, and I had that identity, it was already packaged for me, just waiting for me to put that uniform on. And then it's taken away. And that can be incredibly disorienting to figure out who you are outside of that uniform. And for me, you know, I landed at Michigan State. That's a very large campus full of a lot of students, and none of them really had my experience in my school. Like, I had 3 non-traditional students. So that can be really challenging to try to figure out who you are, how to access care that you never had to before. And also, like, if you don't call yourself a veteran, how do you seek services under that header if the only question that's ever asked of you is, are you a veteran? I would have answered no to that, because I didn't think of myself as one. I didn't want to have anything to do with the military right away. I was figuring out who Andrea was. So it can be incredibly challenging to even get access to care, to know it exists, and to really get the care that you really need, because it is a very high risk time for veterans during that 3-year transition period. So it's a lot of other things, and that, no, you can keep going. And that's really a lot of what the mission of the Michigan Veteran Affairs Agency is really being that conduit, that central coordinating agency. So all of those services that I could access, if I knew, where to go, there's so many things out there, and it can be very confusing if it's up to the veteran to figure out and wade through the waters. And that's why things like the health information exchange, talking about streamlining, having that one access point, that can be hugely helpful. And that's where MVAA is kind of that central coordinating agency for a lot of veteran resources and services. It's not developing a lot of programming, it's helping connect folks to that, to those resources. Next slide. And we do fall, just as a point of information, we do fall under the Michigan Department of Military and Veteran Affairs, which is alongside our Air and Army National Guard and our Michigan Veteran Homes, which we have 3 now. We have them in here in Marquette, where I am currently. And then we also have downstate at Chesterfield in Detroit area, and then in Grand Rapids. And then the Michigan Youth Challenge Academy is also a part of the Michigan Department of Military and Veteran Affairs. Next. And like I said, it's really about trying to connect veterans and their families to whatever federal, state, or local resources that they can access. It's really, and the Resource Service Center, that 1-800-MICHVET, that's almost like, if you're familiar with 211, it can be it's very similar, and it is manned by 211 operators outside of our call center hours. It's really not just for veteran resources. Wherever that veteran or family member is calling, they can connect to community resources in that area. So it can be a really helpful thing even if someone is well connected, they might not be accessing everything they're eligible for. So it can be a really helpful, line to give to veterans that come to you, or even for you to access to find out what resources are available. Next slide.
Thank you, Andrea. My name is Kayla Traxel, and I'm another co-facilitator from MiHIN. I'm a project manager of our cross-sector data sharing department, and I help gather everyone for this presentation today. When we sent out the registration, we had a small poll, and I wanted to take a moment to review the answers from that. So could we go to the next slide? Thank you. The first question was just, is identifying a veteran and getting them to the resource something that your organization is focusing on? I don't want to spend too much time on this, but I do want to draw attention to, are you just screening, or are you working to get them to that resource? Next slide, please. Next, we had a wide range of tools that were used to capture veteran status. I noticed that there were a lot of others, and we have a discussion later on that we can focus on talking about this, but I would love if you could drop in the chat, if you put other, what kind of system or tool are you using? And then also, if you use both an EMR and a screening, what is your intent or reasoning to capture that information twice? Next slide, please. And then lastly, when do you ask a person for your veteran status? Same goes for the other and for the both during screening and registration. We have so many who don't currently, but it's not everyone who attends this webinar is a care provider, so it might just not be applicable. So I want to focus on the during registration. How do you ensure that that information is then contributed to their care and that it's not just a checkbox? So these are some things to think about for our discussion later. If we could go to the next slide, we actually have another poll to get your minds turning on this that will have you complete in the pop-up window. And we'll go ahead and move on to our next presentation, so feel free to multitask and look at those questions, and can't wait to discuss. Thank you. I'll pass it on to Dr. Bonesack.
Thanks, Kayla. So can everybody hear me okay?
You sound great.
Okay, perfect. All right. Hello, everybody. Really excited to be here today to share some of my experiences. And in fact, when I woke up this morning, I'm like, why am I talking today? And I realized, and by the way, I'm he, him pronouns. And in this case, I almost feel like I'm we, they, and I, because I'm talking to you as a we, as a veteran, because I've served. They, because sometimes I, as a provider, am providing care to a group of people, a population, as Andrea talked about. And then the I is me personally, in my own experience as a veteran, trying to navigate the healthcare system. And I'll provide some anecdotes about that. So again, as I mentioned before, I'm a family doctor, so I had the pleasure of working inside a rural primary care clinic for 11 years, taking care of many patients within the community where I was serving. And through different leadership positions, migrated towards the concept about population health. And really that has to do with looking at the holistic approach to a patient. It's not just their medical care, as Andrew was pointing out in her nice anecdote, it's all that other aspects of environment and other factors that come into what your health is. And I will say my transition from active duty was a little bit easier, quite frankly, because I joined the Air National Guard and I could still serve with my brothers and sisters here in the state of Michigan for another 11 years under the same banner of the department that runs the military arm of our state government within the Michigan Air National Guard. And so amazing pleasure to essentially have a dual role of both civilian space and as well as working alongside my military veterans. And sometimes we'd actually run across some of the same things. And I think it's those multiple roles that I saw that really drew me towards thinking about how we could be doing things better. And so just recently, I now precept in a family medicine clinic within the Livingston County area, ran across a patient, and her record was scant. But she came in with all these different chief complaints. She said we didn't have anything about her health maintenance. So she was due for a mammogram. She was a little bit older, so 45 and older, needed a colonoscopy. We had 0 records for her. And so I was browsing through the chart. The resident was precepting with me, and I was like, wow, there's no records anywhere. And then I also then saw one of her issues was migraine headaches, and she was wanting help with that. What's the last clue? I looked under her insurance. It was TRICARE, right? And so if you're familiar with TRICARE, that's one of the military insurances that allows veterans to receive care or their dependents. And the resident wasn't aware of what that sort of insurance entails. So when I went into the room, I was able to immediately connect to the person to connect the dots on why we were essentially working inside an information vacuum. We just didn't know what was happening with that patient's prior care because we weren't exchanging the information that we need to do through some sort of set exchange, is what Joanne had pointed out at the very beginning of what MiHIN does. And just for full disclosure, I'm actually on the MiHIN board. I joined out of that passion for wanting to see better connectedness to our patients. And my other anecdote along those lines is I just arrived from the Air Force. I'm sitting in my civilian practice, and a patient tells me, "Oh," and this is a regular civilian patient, not a veteran. And I said, "Hey, what's going on with your kidney function?" They said, "Well, I just saw the nephrologist last week. I looked through the record. I could not find even a creatinine to know what the nephrologist had tested." And I thought that was just crazy because I then was actually interviewed about how we were doing our electronic exchanges. This is 13, 14 years ago. I gave the anecdote. When I was in the military deployed to Kyrgyzstan, we had a patient that had a heart attack. I was able to follow him through the entire continuum of care, all the way to DC, getting evacuated through Germany. I saw everything that happened to him. And that's the joy of working inside the military medical system, is it is compartmentalized, but very efficient of exchanging information. And I think we're still working on that in the civilian side. And that's what my passion is around connecting those dots and providing better care. With that patient, back to what I was talking about before, just a few months ago, we were able to eventually obtain her records and figure out what she needed to have done. But again, it was inside that black box of the military medical system that we don't always necessarily see in the civilian side. We don't always identify it either. And that was the why behind the what of the challenge that we were having. Next slide. So Andrea talked about exposures. So been there, done that. I had 4 deployments to Iraq, Afghanistan, Kuwait, Kyrgyzstan, another last deployment to United Arab Emirates near Abu Dhabi. These pictures are all from both Kuwait and Afghanistan, along with some training that we did in the Air National Guard on the far left-hand side of air medical evacuation. But you talk to a veteran, they've been somewhere. And yes, I've been to some of those places overseas, but everybody's got stories of people who were here when we first arrived. Andrew and I were just exchanging anecdotes. Hey, where you been? What you done? It's always an immediate connection that veterans have. And that just opens doors when you ask a veteran patient, hey, what you been doing? Where you been? And they've got stories. And in this case, I've had actually a fair number of exposures because of where I had been and deployed. So my favorite story is up the upper left-hand corner of that gentleman that he's doing his laundry. And that's one of my pilots because I was assigned to an A-10 fighter squadron as the flight doctor. We had to hand do our laundry, wring it out over a pit, and then dry it on a clothesline. So, Andrea, you were saying the Air Force gets good deals when you're deployed to some of those other places at early parts of a conflict. The funny thing is his call sign was Prof because he went to Harvard for a master's degree. So you just getting those aspects of people's background is really fun to do with veterans. But what it also does is opens doors about some of the exposures. So I will be personal here in a fair number of my anecdotes. I'm actually in the burn pit registry because I was exposed to a number of different things, and that puts me logged in with the VA system. And it's amazing how many veterans I've run across that have not initiated that aspect. So when you're a care provider out in the community, you identify somebody, you really have to nudge them towards the realization that if they can just get on some of those registries, they may be eligible for extra care or other screenings down the road. I personally was then eligible to make sure that my lungs were okay. I had a pulmonary function test at the VA Ann Arbor after I was on the burn pit registry, just to make sure that I didn't have any functional capacities that had been compromised from my exposures downrange. Next slide. So specifically, I was asked to outline a little bit more about what's called the MilVet program within Trinity Health. It really outlines a lot of the things that I just talked about. The fact that we as community providers need to understand better what those medical and mental impacts can be on military service. And that's both dependents or both the military veterans who've served, as well as sometimes even their dependents. People move a lot, and that lack of continuity affects the dependent families as well. And I know Andrea and the MVA, it's a support of not only the veterans, but the whole family approach is really important to how we're taking care of our vets. And in addition, there's that social and culture exposure. And that's where we get really excited about what that esprit de corps can be, that bonding. And I don't think I would have forgiven Andrea if she hadn't said at least once the word mission. And that is really that shared mission that we all share when we serve together. And that's really what bonds us together. So how does that culture then affect how we deliver care? And that's what the MilVet program within Trinity Health has tried to impart through some trainings that we have that I'll talk about a little bit later. But on to the next slide, that describes some of that aspect. So you can click through all those 5 different dot points, and I'll touch on some of them through some larger, bigger picture pieces there. So first, I want to call out myself. So if you guys can see my screen, I've got all this paraphernalia on the wall here. Now, I captured that for my last duty station when I was state air surgeon up at Joint Force Headquarters in Lansing. And we jokingly call it the I Love Me wall. And the I Love Me wall is all those certificates, all these little things that maybe your kid drew a picture when you were deployed and sent it to you, and you frame it, which is what that was, or flying a flag on behalf of a loved one, the flash tails on the Air Force side. Every culture, every military group has their own aspects that they think fondly back on and try to remember. And what is that about? It's that pride, it's that collective identity. It's how you really build that esprit de corps within a group that has a shared mission. And what we find, I think, when you get out of that culture and go into the civilian space, it's not always apparent through that shared mission and shared values on the outside. And so, connecting to a military veteran when you're seeing them as a patient, tapping into that and getting that passion that they probably have from their experiences for that cohesive unit that they would have been a part of. Those shared beliefs, that collective strength that everybody has together. And finally, it's just about service. And each service has their core values. And within the Air Force, it's integrity, service before self, and excellence. And any Air Force person can rattle that off anytime. In the Army, the Marines, the Army, Marines, Navy, everybody's got their core values that they ascribe to, and they internalize it forever. And I will say, I just got chills saying it. It's something that's a part of us as we serve. We bring that passion and that connection to where we then interact with our colleagues. Next slide. So unfortunately, after all those exposures, all the run around the world and or in the United States, doing a lot of moves and other things, and quite frankly, even the people that just have 3 to 4 years in service, I've run across a fair number of Vietnam vets, and they're wearing the hat, Andrea. They're looking all, Vietnam veteran style. They might have served only 2 years, but that's not only 2 years. They're in Vietnam. They were in some other place. And we always have to acknowledge that time is not necessarily fully related to what the downstream consequences can be from some of those influencers. So you can see here on this slide, I'm not going to read, I was taught long ago by my pilots, Doc, don't ever read word for word off a slide because you get thrown out of the room. So you can read just as well as I can all the different, the delta here, the difference of those who've served and not served for a fair number of chronic diseases that we need to be aware of if we can identify those veterans that are in the community and just ensure that we're addressing that cultural aspect, but also what some of their exposures and or service may have influenced. Next slide. So I hope you've understood and heard from me anyway that we have some gaps. And so unfortunately, we don't get that training necessarily in our different schools. I can't remember in medical school getting even one lecture about military veteran care. We had exposure to it when I rotated through the VA, but even then it wasn't really an orientation that I can say I truly understood what I was dealing with when I was talking to a veteran, and that was before I had started fully serving. Other aspects that I already touched upon are that relevant knowledge towards how healthcare is delivered. And so thinking about those disease conditions and, quite frankly, connecting patients after you identify them with some of those exposures to what their benefits might be. And so, again, I already shared how that veteran connection can give you additional healthcare opportunities if it's identified, say, through the PACT Act or through the Burn Pit Registry, or even just regular service through a service-connected disability. There are additional services that you can receive. And there's also a system through the VA where it can be collaborative care between the civilian provider and the VA. And so there are people that are specifically charged to coordinate care between those two entities. And so a couple of stories about that. Just a few years ago, I was diagnosed with type 1 diabetes, started losing weight. My eyesight didn't go was out of the blue. I have an autoimmune disease, age 50. And unfortunately, due to some healthcare insurance changes, I learned that the cost share for some of my medications was going up on my civilian side. And I was like, man, wait a minute. I haven't gone to the VA in a few years to establish care there. I go to the VA. I realized that with a partial disability and other things that I might be eligible for care. And I was able to streamline some of my medications and other things that I'm getting for my own care of myself through that shared benefit. But again, it was myself nudging myself as a patient, hey, go after that and see what could be explored. And one aspect, and that's me talking about my care as a doctor and as a patient, but I'll tell you what we promote in terms of how we address healthcare within Trinity Health, it's about the team. right? The care team is not just the doc, it's the nurses, the care managers, the pharmacists, administrative support people. If we don't identify vets and what their needs are, then we're not taking care of the whole person, and we're not necessarily always connecting them to the care and the services they might be able to be eligible for. And so that's what I really like about the program, at least how we've outlined that, is to highlight the fact that the full care team needs to be aware of the aspects of veterans care that need to be addressed. So you can go on to the next slide. So kind of a snazzy, Kayla put these slides together there. So no, don't go away yet. Go back to that screen. Okay. So Kayla, I gave a few different screenshots of the things that we do within Trinity Health. And this is just one example of a module that we have as part of the MilVet program that is just one of many modules that talks about why it's important to be caring for veterans and identifying them, but then some of those other aspects that go way more in detail about the cultural components of what it means to serve, then onto exposures and other chronic diseases that might be applicable to a veteran that you're caring for. So we do have these modules out there. We initially had a big push a few years ago to have people that were onboarding taking that training. That has since, during COVID, kind of fallen out of a requirement per se. But for example, I was orienting to some of our community health workers the other day in a really nice meeting, and presented aspects very similar to what I just gave all of you today about veteran healthcare. And they said, hey Kevin, where can we learn more? And I said, oh, go to our online modules and you can learn a lot more from that. And so I gave the hyperlinks and everything else. So again, wonderful content to provide the foundational course, and then additional drill downs into the details about what can be done to highlight the importance of how we could be providing better care for our patients, especially when they're identified as veterans or family members. Next slide. So in summary, a successful team beats with one heart. There, I read a slide straight word for word, but I think that quote is really nice, right? If we can get at the heart of our military culture, figure out how we can address those things that really they see as values and we value them, we can go forward with this sort of mindset and be better taking care of our populations that we're serving. So with that, Kayla, I think I've stayed on time to then open up for this group to talk about other things. So back to you.
Okay. We will actually have an announcement from Andrea on one of their projects. So Caitlin, we can go ahead and skip ahead again and again. And I will pass off. Oh, let's go back to yes. And so I will pass off to Andrea, who has a short update.
Oh, no, I don't think I can hear Andrea,
I can't either.
which is weird. I don't see that she's on. Yeah. Nope.
Okay.
Hmm.
What we can do is move to the discussion just for now. And if Andrea, you work through the sound, just let us know and we'll jump back. So let's go ahead and move ahead to the next slide. Nice. So that poll that was sent out asks a lot about screening practices and really getting down into the weeds of what do you do with this information and how can you help potentially connect veterans. It's really creating an awareness around the identification and screening process. The reason we are asking these questions is because under the MidSong grant, that's what we were awarded to do, to start creating awareness around these screening practices and then provide them with these responses so then they can act on it. And hopefully it can lead to even more opportunities with this new information, because these are questions that aren't fully answered or understood. Someone did note that they can see Andrea back on camera. Can we hear you, Andrea? I cannot hear you yet. So I will keep talking, but interrupt at any time when we hear you. Um, so through the poll that was sent, Caitlin, are you able to pull up the results so we can see them on screen?
Yeah, of course. Give me 1 second.
No, Kayla, while you're pulling that up, I did mean to mention that we have pondered ways to have a flag, literally a flag in the demographic tab to identify veterans. But just like a lot of other influencers that we might identify, like transportation needs, food insecurity, etc., there are some even veterans that have said, I don't necessarily want to be automatically identified. So giving choice, I think that does resonate with some of the things that Andrea had mentioned too about sensitivity to ensuring that we are encompassing that full person and acknowledging their own preferences for how they are identified. So that was an interesting aspect that we did not anticipate coming up when we were considering the demographic identification.
See, I think there were eight responses, but we have
Okay.
so many more people here. If you didn't participate in the questions in the poll, was it because you didn't know or you couldn't get it to work? Just trying to make sure that people know what to do. Andrea, can we hear you now?
I don't know. Can
Yes,
you?
we can.
Yes.
Yes.
Yeah,
Yay.
it's really strange. It was working and nothing changed. I didn't touch anything and then it just stopped.
Of course. Well, not Caitlin, I hate to switch it back on you, but can we go back to that other slide for the collaborative linkages? Thank you. Thank you for being a trooper.
Well, the collaborative linkages for older adults, like that is a grant funded initiative to really try to, I look at it as trying to make sure that area agency on aging, like the different programs for older adults are veteran culturally competent, and that veteran spaces are culturally competent about the services for older adults. There were 4 different points to it, which is to introduce veteran cultural competency training, aging services, and special program awareness. So like really getting the information about the older adult services out there, and also veteran referral tracking and a marketing campaign. Those were all aspects of this grant. And as of last month, let me see, April 2nd, and trained 387 individuals on veteran cultural competency, including 8 area agency on aging facilities. There's a partnership that was developed with the MSU Institute of Health Policy, and that's to conduct key informant interviews and really collect some data to evaluate the initiative and see how it's working and enhance that referral network, which is vital. It's really, I mean, that report from those key informants, that will be out in late fall, but really, this is an area that I know a lot of veterans don't understand, that there are community resources that they can also access. Not everything has to have the veteran label, like, because I like to think of veterans as a population that exists in every community, not that it's its own community in of itself. Of course, there are, groups of veterans that get together as a community, but veterans exist in every community. So really making sure that they're connected to everything that can help them thrive is imperative. And as our veteran population is aging, these resources are vital, because we can't always, one agency is never going to do it all, nor should they. We all have to work together. So there is a call to action kind of if you will, that if you do work in a AAA, that you do also try to get this cultural competency training. We mentioned it, both myself and Dr. Bonesack talked about the importance of it. And it's really, I mean, just like with any person that is that is seeking care, understanding they are a whole person with multiple identities that intersect and that will affect healthcare, but also knowing that if you're making that referral network is strengthened, then everybody is utilizing their resources to the best of their ability. There's not duplication of effort. There's not, if you're able to make a really solid referral, that frees up your resources to help another individual. So understanding your population and the different identities is important. But also, if you have the opportunity as a key informant to participate in these interviews, that helps the data. And if you have success stories about working with veterans, that could be included in that marketing piece that you talked about. That's also requested for this. So that's, like I said, in the fall, late fall, that's when this report should be released.
Thank you, Andrea. It's very helpful. It's nice to see that project work is already occurring around connecting veterans with other care networks.
And just as a point of information, we do as an agency provide cultural competency training to organizations all the time. We have plenty of staff members, myself included, that have talked about, the veteran population to different organizations, healthcare related and community related. So the information is certainly out there, and really be happy to get people more up to speed on taking care of their veterans.
Ava's got her hand up.
Thank you, Dr. Bonzak. Excellent presentation. Full disclosure, my husband was the state surgeon for the Army National Guard for many years, and very similarly to Dr. Bonzak, was deployed all over the world. The question that I am actually posing, the questions that I'm posing, number one, does anyone know whether CAQH captures the practitioner's veteran status so it can be listed in the provider directories? I'm not aware of that. I have not asked that before. So anybody on the call that is familiar with the CAQH application, I pulled some information up. I don't see anywhere where Dr. Bonzak, you could go ahead and indicate that you are a veteran and you accept veterans or however they would identify it in the directory. Anybody know whether that's captured at all?
Eva, what does CAQH mean?
So it's a system that physicians and other practitioners, it's a data capture system. So when you go into practice, you enter all of your demographics, you enter anything that the payer chooses to extract and put into their directory. So languages spoken, accessibility, hours of operation, where you went to medical school, where you completed your residency. But just in a cursory glance, I didn't see anything where people could actually put in their military status. So I'm going to pick on you, Dr. Bonzak. Maybe that's something that would also enhance access to care.
Yeah, so number
And it
one,
would
I
allow-
kept the same license my entire military career for
Right,
28 years.
Yeah,
So license was different than having theoretically an NPI number that was
Yeah.
under the military. But then
Right.
I got assigned a new NPI as I came into my civilian organization.
right.
So
Right.
that's the only thing that I could think of, is that there'd be a different NPI that could be retrospectively identified because it was somehow affiliated with a military organization.
Well, I don't think
yeah.
the military attaches NPIs. You've got a group 2 NPI number because of your affiliation with your current practice, and you've got a
Right.
type 1. But I'm looking at the overarching application that is completed by every single
That's not,
person.
I've never been asked that question.
So maybe
And I think that is a charge, though, I think, to all of healthcare organizations to consider ways to even flag that training that Andrea's, identifying. So we have, worked with different aspects of how we deliver care and where we are open, if you will, to different populations that we're serving. Is there a way to identify providers, healthcare teams with
I
that
feel-
familiarity? I think that's one of those opportunities that we could be better at, because there's a lot of assumptions that, oh, well, veterans only get care at the VA, when the fact of the matter is the majority of care actually is out in the civilian population, and we're some of the least prepared to understand those exposures and other disease states that are linked to military service.
And I will say this too, that even within your organization, how does your organization celebrate its veteran employees? It can also be something that within the organization itself, that that they share that information with their patients, that this is something that they have some visible identifier that indicates that they are in fact a veteran. And we do even have programs at the at MBAA, the Veteran Connector Initiative, that there's certain criteria, but they're pretty doable. But even a healthcare organization could sign on to become a veteran connector, and they get that visible identifier on their website that indicates that they are one, and that they are able to make that referral, like I said, even if it's simply to give 1-800-MISH-VET information, like that, the resource call center line, and they have some information on their website about veteran resources and how to connect. There are ways that we want to celebrate organizations that are really taking that on, as that they care about the veterans that are seeking services, and that they are vocal about that care. So there's
my
ways that
my Trinity Health badge is in my car right now, but I got a special little thing that says veteran as the little thing, the little doohickey that has your badge on it.
and it's just like
You,
with the
you
well,
guys,
just
you
like
guys
with-
might think that sounds so trite, but like I wear that with pride. In it, for this thing, I wear my retired pin, and I wear that on my white coat with an American flag when I'm in the clinic.
And
So
we have
those are
veteran
different things that we
pins.
do.
Yeah, we have veteran pins, we have veteran spouse pins, we have family, like we have, and those are not just a fun give me at an outreach event or something. And when you wear that, that indicates to that veteran that you might get it, you might understand me, I might be more apt to open up.
We have
It's just, go ahead.
We have another question in the chat. Do we have health informatics standards for identifying relevant veteran data? And I know that recently even veteran has been flagged as a potential like SDOH domain by the Gravity Project. But I think there's just a lot more to be learned, that even if we have the standard, it's ensuring that you're delivering the appropriate care. Andrea and I had a discussion on even phrasing the question correctly within providing care.
That's a really good point. How you ask the question, how are you screening for veteran status? Because if you're asking the question, and it took a long time to even get, are you a veteran on an intake assessment, even just getting a screening question. But there is a best practice way to ask that question, and it's not dependent on self-identification. Have you served? Have you or a loved one served in the military? That's the best practice way to ask that question, because not only does it screen for that particular patient and whether they have served, they don't have to call themselves a veteran to answer in the affirmative, and you can still get them into care. But if you even take it a step further and ask if they or a family member, the person that's in your office might have a spouse that served, and they might be in your office for something else, but they really could use some additional support to help take care of that veteran. So if you're screening broadly like that, then they can get access to the care they need.
And I just put in the chat again, I think this is an ongoing conversation, in a sensitive way, identifying veterans, having that some sort of a flag. love to keep this going in some sort of a dialogue because it is something that I'm very passionate about and would love to see within our own record so that that sensitivity, as Andrea's talking about, could be further brought to that cultural awareness that we're looking for. But anyway, back to you, Kayla. Oh, Carol's got a question.
Yeah, I know we are at time. I'm happy to stay on.
I'll
if
stay
others
too.
are.
Yeah.
So if you can see, I don't see the exact question you saw, Dr. Bonsack. You said from Carol.
Oh, Carol Heiso,
Um,
she has her hand up.
oh,
Oh, it went down again. Maybe that was just a.
okay. Do we have other questions? I do see Jim
I
asked.
let Carol unmute, so if she
Okay.
did want to speak, we'd
I think
absolutely be happy.
am I unmuted now?
You are, and we can hear you.
Okay. I just wanted to let folks know that at least in the community mental health setting in Michigan, our funded programs, we have a series of questions about veterans. We do ask it the way like Andrea talked about, have you or anyone in your family ever served? And we changed it to ever because when we were asking the veteran question, the federal definition was so narrow that we missed a lot of people, but we have to ask it that way because that's what they require us to ask. So we move that way to the end of the questions, and we first ask, have you or anyone in your family served? What era did you serve in? What branch did you serve in, or that? And what that does is if our intake staff, number one, they try to pair that person with a therapist that has some experience, either is a veteran themselves or has further experience in that. And the other thing we have in community mental health is we have what we call a veterans navigator, and that's someone within the system that navigates them to other services that they may be eligible for, or their family may be eligible for. So this whole thing is very interesting to me to find out what other services there are, so I can make sure our navigators know. And I just want to let other folks know that we do have that in our systems.
The chat is very lively too. And I didn't want to leave your question unanswered if if you wanted like specific technical information. I don't know if I can speak to it, but I'm happy to connect offline. And I appreciate you weighing in on what questions you're asking as well. And then Mary Kay, I see you dropped the HL7 fire resource for military service, so that could be worth looking at. I do know that fire is a very new standard, and so I don't know if the military service one is open for comment anywhere or from like a fire connect-a-thon, but again, very happy to meet offline. I'll leave it open to any other questions or any other comments before we sign off today. And thank you again, Carol, for talking.
Thank you everyone for joining, and it does look like all of our speakers and facilitators have put their contact information in the chat as well. So if you would like to reach out to any of them, please use that contact information. We'd love to hear from you. Otherwise, thank you so much for joining, and we will see you next time. And thank you, Dr. Bonsack and Andrea.
Thank you.
It was a real pleasure. Thank you so much.